I'm Tsukasa Saida from University of Tsukuba. I have no conflict of interest to disclose this presentation. Pregnant women often present abdominal pain, which can result from a variety of conditions. Radiologists collaborate with obstetricians to choose the appropriate imaging modalities and provide accurate diagnosis, depending on the underlying cause of the pain. This lecture will explore the causes of abdominal pain in pregnancy, both pregnancy-related and non-pregnancy-related, and will cover imaging findings, diagnostic approaches, and treatment strategies for management these cases. In a survey on abdominal pain in pregnant women, we as radiologists become involved when imaging studies are performed. The causes of acute abdomen during pregnancy are considered according to this flowchart. An ectopic pregnancy is one of the most important examples of pregnancy-related conditions. Ectopic pregnancy can be considered in cases of acute abdominal pain in women of reproductive age. The incidence of ectopic pregnancy is 1 to 2%, and ruptured ectopic pregnancies are responsible for 6% of maternal deaths. Approximately 2% of natural pregnancies and 4% of pregnancies are under assisted reproductive technologies. About 96% implant in the fallopian tube and 70% occurring in the ampullary lesion. Risk factors include a history of pelvic inflammatory disease, smoking, fallopian tube surgery, and previous ectopic pregnancy and infertility. When a pregnancy test is positive but no gestational sac (GS) is observed within the endometrial cavity, suspicion arises. Ultrasound is typically sufficient for diagnosis in most cases. Atypical cases such as interstitial, cesarean scar, peritoneal pregnancies, and unruptured cases may require MRI. Because ectopic pregnancy cannot be sustained, contrast-enhanced imagings are considered acceptable. Treatment options include surgical intervention, medication, and conservative treatment. In cases where an ectopic pregnancy has ruptured and caused significant bleeding, mother's life may be at risk. Therefore, accurate diagnosis of the GS location and sites is essential. I will talk about a case of a 37-year-old woman. This patient was referred to our hospital because of genital bleeding. Her serum HCG level was 1046, which was higher than normal. A tumor-like lesion with low signal intensities on T2 weighted imaging is seen in the uterine cervix with no contrast enhancement. GS is not observed within the uterine cavity on MRI and ultrasounds. It is found in the cervix. Diagnosed with cervical pregnancy and treated with methotrexate therapy. Next case is 38-year-old woman with vulvar pain. On ultrasound, the GS is not seen in the uterine cavity, but is located in the cesarean section scar. On MRI, the anterior uterine wall is thin and shows a scar from a cesarean section scar. A cystic structure, likely the GS, is seen. An embryo is located in the left dorsal side indeed. A total hysterectomy was performed and GS was identified on the site of the previous cesarean section scar. Next case is 32-year-old woman with acute abdominal pain and hemorrhagic shock. Dynamic contrast enhanced CT shows that right side of the uterine fundus is open to the abdominal cavity. A cystic structure that looks like a GS is seen near the right tubal angle. The leakage of contrast agents suggests active bleeding. An emergency surgery was performed, and the isthmus of the right fallopian tube was ligated and dissected to control the bleeding. In emergency with heavily bleeding, contrast-enhanced CT is used for diagnosis. Because the situation can be life-threatening for the mother, it is important to perform imaging studies without delay. Next topic is ovarian torsion. Ovarian torsion is a gynecological emergency where the ovary twists, either fully or partially, cutting off its blood supply and causing ischemia. It happens in 10 to 20%, 28% of pregnancy, with an incidence of 1 in 1,000 to 5,000 pregnancy. About 95% occurs in the first trimester, and the riskiest period is before 20 weeks of gestation. 60% occur in the right side, and 60% are due to teratomas. Ultrasound is the first-line diagnostic assessment. MRI can help diagnose ovarian torsion when US findings are unclear. CT is usually not performed for ovarian torsion because of radiation concerns, but it can be considered when other possible causes need to be ruled out. The twisted pedicle shows a spiral-shaped soft tissue. As ischemia progresses due to torsion, the ovary enlarges due to venous obstruction, reflecting edema and becoming high signal intensities on T2-weighted imaging. When arterial obstruction occurs, contrast enhancement disappears. Ovarian torsion requires emergency surgery, so accurate diagnosis is necessary. MRI is suitable for local evaluation when the diagnosis cannot be made by US. This case is a patient at 33 weeks pregnant with right lower abdominal pain. A cystic mass located in the right annexa with a whirlpool structure observed. On T1-weighted imaging, high signal intensities of fat component is observed, suggesting a mature teratoma. During surgery, the right ovary was twisted 720 degrees and congested. Pathological diagnosis was a mature teratoma. Next case is a patient at 20 weeks pregnant with right lower abdominal pain. A cystic mass is located in the right adnexa with low signal intensities at the periphery, suspicious of hemorrhage. Whirlpool structure is also observed. During surgery, the right ovary was twisted 540 degrees. The cross-section shows a mixture of blackish to reddish areas containing both solid and cystic portions. The final diagnosis was a mature teratoma. The next topic is red degeneration of uterine leiomyoma. Red degeneration of uterine leiomyoma is hemorrhagic necrosis due to venous infection of uterine leiomyomas. During pregnancy, rapid uterine enlargement complex veins leading to red degeneration in 10% of leiomyomas. Risk factors include pregnancy, oral contraceptive use, and steroid intake. MRI is preferred for diagnosis. Typically shows low signal intensities on T2-weighted imaging and high signal intensities on T1-weighted imaging with no contrast enhancement. The periphery shows high signal intensities on T1 weighted imaging and low signal intensities on T2 weighted imaging. However, these findings may not appear right after the onset. Keep in mind in cases of acute abdominal pain in pregnant women, uterine leiomyosarcoma often shows hemorrhagic necrosis inside the tumor. A key difference is that leiomyosarcoma, the hemorrhage is mixed within the tumor, while in typical red degeneration, the entire leiomyoma undergoes hemorrhagic changes. Red degeneration can be managed conservatively, so accurate diagnosis is necessary. This case is a postpartum patient with abdominal pain and fever. Our well-defined mass is identified in the uterine body. The mass shows high signal intensities on T1 weighted imaging with no contrast enhancement. The margin of the mass shows limb with low signals on T2 weighted imaging and high signals on T1 weighted imaging. Findings consistent with hemorrhagic infarction of the leiomyoma. After surgery, this was diagnosed as red degeneration of uterine leiomyoma. The cross-section appears yellow-brownish with no evidence of necrosis or bleeding in this case. The next topic is ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome, OHSS, happens due to medical overstimulation of the corpus luteum. It causes both ovaries to enlarge, triggered by high HCG levels. This condition can lead to bleeding inside the cyst, cause abdominal pain, and in some cases torsion or rupture. Mild cases may develop in 20 to 30% of all in vitro fertilization cycles. In moderate to severe cases, there is a risk of acute renal failure, acute respiratory distress, or venous thromboembolism. In cases of ovulation induction medication administration, monitoring is typically done using ultrasound. CT or MRI may be performed if the patient has severe pain to rule out other conditions like torsion or pelvic infections. Both ovaries are enlarged and demonstrate much locular cysts of varying sizes. Ascites may also be present. Sometimes differentiation from metastatic ovarian tumor is necessary. Since conservative treatment is preferred, an accurate diagnosis is essential to avoid unnecessary oophorectomy. This case is about a woman in infertility treatment. She had ovarian stimulation and felt sudden lower abdominal pain 2 days later. Both ovaries are enlarged with multiple cysts. The cystic wall maintained their structures and showed contrast enhancement. A collapsed cyst wall is observed on the posterior aspect of the right ovary, accompanied by ascites, indicating a ruptured follicle. The symptoms improved spontaneously with conservative treatment, and the patient was discharged 3 days later. This summer vacation, I traveled to Da Nang, Vietnam with my family, and we had many good experiences and made some wonderful memories. Thank you. Next, I will talk about pregnancy-unrelated conditions, starting with gastrointestinal disorders. Complications of acute appendicitis occur in about 1 in 700 to 1,500 pregnancies, with most cases in women under 30-year-old. If appendicitis leading to perforation or peritonitis, the risk of miscarriage increases, and pregnancy outcomes may worsen. Therefore, prompt surgery is generally recommended. Diagnosis via ultrasound is often challenging during pregnancy. MRI recommended over CT to avoid radiation exposure to the fetus. However, in emergencies, MRI is often difficult to perform, so CT may be prioritized. Ultrasound can reveal appendiceal swelling, wall thickening, and surrounding fluid accumulation. Similar findings can be observed on CT or MRI. Incursions of perforation or abscess formation as well. As the uterus enlarges, the appendix also shifts upward. Furthermore, the gravid uterus can complicate the clinical picture. Therefore, prompt diagnosis is crucial. This is a case of a patient at 7 weeks pregnant with right lower abdominal pain. On ultrasound, appendix is enlarged to 10 millimeter at its base and contains phalanges. There is a GS in the uterus. The appendix wall appears thickened, with distal portion measuring 11 millimeter in diameter. The appendix shows marked restricted diffusion, indicative acute appendicitis. After surgery, pathological diagnosis of phlegomatous appendicitis. Next, I will talk about cholecystitis. Cholecystitis is the second most common gastrointestinal condition requiring surgery during pregnancy. It occurs about 1 in 1,600 to 1 million pregnancies, with over 90% caused by gallstones. Hormones like estrogen and progesterone during pregnancy cause biostasis, increasing the chance of sludge or stones. The recurrence rate after conservative treatment is higher during pregnancy compared to the general population. Laparoscopic surgery is commonly used and generally safe, but in late pregnancy, there is a higher risk of conversion to open surgery and preterm birth. First, an US is performed. An MRI is used to confirm the bile duct's course and check for stones in common bile duct before surgery. This allows for diagnosis without radiation exposure, so CT is not usually performed. US can show an enlarged gallbladder and thickened walls with sonographic Murphy sign. Gallstones are often present, and some may be trapped. Similar findings can also be seen on CT or MRI. Care should be taken for perforation or abscess formation as well. Accurate diagnosis is prompt, and prompt treatment is essential. This is a case of patient at 13 weeks pregnant with upper right abdominal pain. On ultrasound, a fetus is observed in the uterus, and a stone is seen in the neck of the gallbladder, and gallbladder wall is thickened. On T2-weighted imaging, the stones appears as low signals, while the thickened gallbladder wall shows high signals intensities. These findings are consistent with acute cholecystitis. A laparoscopic surgery was performed, and after that, the pregnancy has progressed smoothly. Urological conditions can also cause acute abdominal pain. Kidney stones occur in 1% of all pregnancy. Ureteral stones increase the risk of pyelonephritis, miscarriage, and preterm delivery. Risk factors include gestational diabetes and preeclampsia. Maternal hydronephrosis is often a physiological phenomenon during pregnancy, caused by mechanical compression of ureter between gravid uterus and pelvic wall muscle, making clinical symptoms important for diagnosis. To avoid fetal radiation exposure, US is the first-line imaging method. However, the detection sensitivity for renal ureteral stones during pregnancy is not always high. The next option is MRI, where T2-weighted imaging can assist in diagnosis and differentiation. If the diagnosis is still unclear, non-contrast CT with minimal radiation is considered acceptable. First, review the medical history and physical examination. If ureteral stones are suspected, consider a testing plan that takes fetal radiation exposure into account. This case involves a 20-week pregnant woman with acute onset of left abdominal pain. A left ureteral stone is present, leading to the dilatation of upper renal pelvis. The patient was monitored with expectation of a spontaneous stone passage. Subsequently, the symptoms improved. In summary, it is essential to properly differentiate acute abdominal conditions that can affect the prognosis of both mother and fetus. Choose appropriate tests based on suspected conditions, considering the impact on fetus and radiation exposure. Ensure appropriate monitoring and treatment while considering the fetus condition. Collaboration between obstetrician and radiologist is essential. Thank you for attention.